We'll shift our talk a little bit now to surgical treatments of obesity, and just a couple of things. The advent of minimally invasive techniques has really revolutionized the field of surgical weight loss to make it safer than gallbladder surgery. And we have people in the room here who kind of work with me and see our patients. These procedures are outpatient procedures or one-day length of stay. Postoperative pain is minimal, return to activity is pretty quick, and the return to function is very, very quick. Procedures are broken down as best we can to what we call restrictive or malabsorptive or hypoabsorptive procedures. Procedures such as the lap band, the sleeve gastrectomy, the biliopancreatic diversion or duodenal switch, and the Roux-en-Y gastric bypass. So when we look at some of these procedures, the lap band is a procedure that I think gained a lot of popularity in the early 2000s for the concept of reversibility. There's no cutting, dividing, rerouting the intestines. You can take it out. And as the field of surgical weight loss evolved, people wanted a reversible option. About 30% of all bariatric surgery was the gastric band in the early 2000s. Now it's less than 1 to 2%. And I can tell you, I haven't put a band in the last few years, and I've taken over 50 out in the last 2 years. So the reason for that is we're seeing these newer medications achieve weight loss comparable to lap bands. The other thing is these are mechanical devices. So these mechanical devices are prone to mechanical failure. You guys drive a Mercedes or Rolls Royce off the lot, 100,000 miles later, you want to trade it in. These bands can erode, the tubing can leak, the band can flip, you can see migration, you can get de novo reflux. There's a lot of problems associated with these bands. And what we know is when it comes out, a lot of the weight loss, they regain. But what we did see is about 30 to 50% excess body weight loss, and the unique features of the band is it's adjustable. So fluid can be placed and fluid can be removed. There's a subcutaneous port that sits underneath the skin. No one can see it, but we can feel it. We can introduce fluid like we do through a Metaport. Fluid migrates through the tubing and tightens up the band like you're tightening up a belt, okay? So we have to find the sweet spot of restriction where we restrict them where they're not eating too much, not overly restrict them where they can't eat, but not under restrict them where they eat too much. These procedures are good for meat and potato type of eaters, big portion eaters, not patients who are snackers, graders, or eat high caloric liquids because they can self-sabotage. They can just put a milkshake right through it, okay? So again, this is a cross-section of it. And it's a nice cross-section. You can kind of see we have stretch receptors in the upper part of the stomach. So when the stomach fills and the stretch receptors are distended, it leads neurofeedback through the vagus nerve to induce satiety or sensation of fullness. Again, there's no cutting, dividing, rerouting the intestines. And patients liked it because they felt that, it was a reversible option. The new kid on the block, so to speak, or the newer procedure, is a sleeve gastrectomy. And the sleeve gastrectomy is the most common procedure done in the world in the US for weight loss. It's a really nice, elegant, simple procedure. What it is, it's a restrictive procedure with what we call hormonal changes. Meaning, the weight loss is not purely due to restriction through a smaller stomach. We see neurohormonal changes by decreasing ghrelin levels. Ghrelin is produced in the upper part of the stomach called the fundus, and when we reduce ghrelin, it induces a sensation of fullness for the patients, okay? So it's a very nice procedure, okay? It's a procedure where 80% of the stomach is removed, and we leave a stomach that's 20% of its normal size. It's performed as an outpatient or one-day length of stay, and there's no intestinal rerouting and lower risk of nutritional deficiencies. Good procedure, very common procedure, about 2/3 of all surgeries. One of the potential complications we can see with a sleeve in pregnancy is that the increased intra-abdominal pressure can cause reflux. So sleeve patients, sleeves are kind of known to potentiate reflux, so we do a lot of preoperative screening for reflux prior to doing sleeves for patients. And we know that sometimes during pregnancy, with a gravid uterus, they can get potentiation of this reflux that usually gets better after they deliver. All right, so this procedure, again, is done, we do it through 4 incisions. The 2 8mm and 2 12mm incisions. What we do is we mobilize the stomach. So we divide the greater curvature aspect of the stomach, taking down all the attachments to the stomach. So here we're using a vessel sealer, okay, and we're mobilizing the greater curvature of the stomach. You can see the heart beating up here. This is the liver. All these patients go on a 2-week preoperative liquid diet to reduce the liver size because we know that this liver reduces the volume of the liver by 30%. The spleen's up here, so you got to be very careful. Underneath this is the pancreas, but we mobilize the stomach up to the level of the left crura or up to the esophagus because we don't want to leave any retained fundus behind that can lead to weight gain or reflux. So the stomach, again, is fully mobilized. You don't devascularize the stomach. The stomach has a very robust blood supply. So once the stomach is fully mobilized, then we place a calibration tube called a bougie. Okay, so we place a calibration tube, different sizes. I use a 36 French calibration tube, and I place it approximately 4 centimeters proximal to the pylorus or the valve. And what we use is linear staplers. These are very smart staplers. They look at tissue impedance. They let us know about tissue thickness. And what they do is they put 3 rows of staples on each side and divides between it. So you can see this is essentially bloodless surgery, and we don't really open up the stomach. There's no spillage of any gastric contents. And essentially we just migrate with a stapler along this calibration tube, this bougie, and create this small capacity, about 150 to 250 ml volume of the stomach. This top part is a fundus, and that part is what produces ghrelin and that hunger hormone. So it's very important to take that out. We also check for hiatal hernias at the time of surgery. So patients have hiatal hernias, we got to fix it. Otherwise, a lot of these sleeve patients can get what we call de novo reflux. Operative time is about 30 to 45 minutes for these cases, and patients tend to do very well, about 60 to 65% excess body weight loss. At the end of the case, we do intraoperative endoscopy to leak test to make sure there's no evidence of intraluminal bleeding. And the stomach is extracted through one of the 12mm trocar sites. And this is a little topical hemostatic agent we place over it. We recreate lateral fixation to the stomach with an omentopexy. And these patients are started on liquids usually within 1 hour after surgery, and some of them are discharged as outpatients. So again, large stomach, about 2 plates of food, depending on how much you eat, but large piece of stomach comes out. Not purely restriction, but neurohormonal changes, so also ghrelin levels, okay? So some of the technical considerations, again, the stomach is divided over a calibration tube. You don't want to leave any extra stomach behind the upper part of the stomach, and you want to make a very straight staple line because some of these patients can get what we call pseudo-obstructions from corkscrewing or spiraling of the stomach, where there's no anatomic blockage, but just a pseudo-obstruction from corkscrewing the stomach. So a very kind of smooth staple line is very important. The other procedure that I think everybody knows about is a gastric bypass. So the gastric bypass is our gold standard time-tested procedure. It's a good procedure. I'm a big fan of this procedure. It's about 30 to 40% of my practice. And it's a combination of a restrictive as well as a malabsorptive procedure. So what we do is we create a small stomach. So the stomach is upper part of the stomach here is essentially the size of an egg. Then we reroute the stomach and we reroute the intestines. We reroute the intestines in such a way that not all the food you eat is seen by your intestines. If your intestines can't see the food, they can't absorb the food. So we create a hypoabsorptive state. Okay, so patients lose weight by restriction through a smaller stomach and hypoabsorption through intestinal rerouting. Just like they're not absorbing their proteins, fats, and carbohydrates to lose weight, they're also not absorbing all their minerals and vitamins. So these patients are committed to lifelong vitamin supplementation. So patient selection is very important for these procedures. Also, this is a very good surgery in terms of metabolic resolution of a lot of weight-related medical problems, but it's also an ulcerogenic surgery, meaning you connect a stomach that's really good at dealing with acid to a piece of small bowel that doesn't like acid, and you can get ulcers at the site. marginal ulcers, we call them. And they occur if patients smoke or chronically take NSAIDs. So very important if you guys have bariatric patients that they do not take NSAIDs or smoke. It's an absolute contraindication for me to do a bypass on a smoker. One of the other things we see with gastric bypasses that's kind of unique to bypasses in pregnancy is that when we reroute the intestines, we create these mesenteric defects, okay? And these mesenteric defects, again, as the uterus pushes up, these patients are lifelong risk of developing something called internal hernias, okay? So internal hernias is where you get a defect in the mesentery where the small bowel kind of herniates through. So if you guys have a pregnant patient with a gastric bypass, abdominal pain, and obstructive symptoms, get your bariatric surgeon involved, because if that small bowel herniates through that mesenteric defect, then they're at risk for ischemia, just like an inguinal hernia or an umbilical hernia where the bowel gets stuck. But usually this is a lot of bowel getting stuck, 100 to 100 centimeters of small bowel. Okay? So this is a little video kind of highlighting things. So again, you can see that we use liver retractors to lift up the liver. So very important that these patients lose weight prior to surgery. We usually mandate a 10% excess body weight loss for these patients because it helps reduce the liver size. The better I lift up the liver, the better I see. We check for hiatal hernias. We enter the lesser sac or the lower part of the stomach, and we use a stapler to create a gastric pouch. So what we're doing is making a small stomach, and we don't really do anything just by eyeball. Everything's done over calibration tubes. So we have our anesthesia colleagues, or CRNAs, pass a calibration tube here to fashion a small gastric pouch. Okay, this is their new stomach. This is how much they can hold. We usually divide the omental fat, basically separating the sea of fat, so it allows it easier for the intestines to come up to the newly formed gastric pouch. This is the transverse colon, and when you lift up the transverse colon, you can see the ligament of Treitz, which is the first part of the small bowel. And here we see the ligament of Treitz, and everything is measured. So we measure the small bowel. Right now we're measuring what we call hepatobiliary limb. So we're running the hepatobiliary limb. We give them about 100 centimeter hepatobiliary limb. Then we bring the intestines up to the stomach, and basically we sew the gastric pouch to the small intestines. So we're creating this gastric jejunostomy here. Once we kind of align the stomach and the small bowel together, we make a gastrotomy, again calibrated over a calibration tube. So you don't want to make this too big. If you make them too big, patients can get bad dumping syndrome. Okay, so we make these pretty small. Okay, and then we make a small bowel enterotomy as well. Not the same enterotomies that we talked about earlier. And we connect the small bowel to the stomach in a hand-sewn anastomosis 2-layer. So now when they eat, food goes from this small gastric pouch into this rouleum or small bowel. And this is why these patients have a hard time with the glucose tolerance test and dumping syndrome, because food now doesn't have this is not a pyloric preserving procedure. Food passes very quickly from the gastric pouch into the small intestines, and you see spikes on insulin and a lot of osmotic loads where they get hypoglycemia. So very important that these patients avoid fatty, greasy, oily foods and hard carbohydrate food. Let me see if I can. So this is the anterior layer. We're just closing the anterior layer here. These are one of our older videos. We now use a liver suspension suture, and we use a unidirectional V-lock suture for these. So once we create this gastric jejunostomy through an omega loop, we divide it. Okay, so now food is going down here. This is called the rouleum. And I can vary the rouleum based on patient's BMI. The higher the BMI, sometimes I make a better, longer rouleum. So I usually give them about 150 centimeter rule limb. We create a interotomy here, okay, into the rule limb. And we create an interotomy in the hepatobiliary limb, the limb where all the gastric and pancreatic secretions meet, okay? And then we use a linear stapler to create a side-to-side functional small bowel anastomosis. Okay, this is the Y part of the Roux-en-Y. You can kind of see the Y part. That's the Y part of the Roux-en-Y. Food goes down this channel called the roux limb. All the gastric and pancreatic secretions meet through the hepatobiliary limb, and food goes down the common channel, and that's where absorption occurs. So common channel is very important. Once we do that, then we leak test and we do intraoperative endoscopy to make sure the anastomosis is patent and there's no leak. And that's the gastric bypass. Operative time is usually about an hour and a half. Patients are in the hospital for about 1 day.